Well, hello, everyone. It's my pleasure to welcome you to our community talk, the latest advancements in treatment options for hip and knee arthritis. I'm Nicole, and I'll be the moderator this evening. First, we want to let everyone know that this talk is being recorded, and it will be available online later this week. We'll be sending everyone that has registered an email with all of the details. For folks that do have questions during the talk, we encourage you to enter them into the chat at any point. We'll be collecting those throughout, and at the end of the presentation, sharing those with the physicians for their comments. So at this time, I'm pleased to introduce our three hip and knee orthopedic experts, Dr. Kevin Kopko, Dr. Max Greenky, and Dr. Anthony Oreo. All three physicians are part of our joint replacement team, and they have extensive training and experience treating patients with hip and knee arthritis. You can learn more about each of them on our website. And we want to thank you for joining us. And I'm going to turn the screen over to Dr. Kevin Kopko, who's going to start us off.
Good evening, and thank you for joining us tonight. My name is Dr. Kevin Kopko. I'm one of the joint replacement surgeons with SOS. I'm going to start the lead on this talk this evening. We'll just jump right in and get started. Most of what we do as orthopedic surgeons, at least in our subspecialty, is treat osteoarthritis. And so the first thing we wanted to kind of talk about, just to kind of give some people some background information, is, what is a normal joint? What are we doing? What are we looking at from one thing to another? So what we're looking at in a normal joint, and particularly the hip and the knee, which is what we're focusing on, is normal synovial joints. So joints are lined with what's called the synovial membrane, and that keeps all the joint fluid together. And then the joint surfaces have articular cartilage, and that capsule and configuration provides a low friction, high mobility surface, which has good wear properties. It absorbs shock and allows us to move the way that we do. The hip joint is a ball and socket joint, just so we can talk about a little bit of anatomy, so everybody's talking about the same things. The ball of the hip is the femoral head. The socket is the acetabulum. The femur is the thigh bone, and the junction between the femur and the femoral head is called the femoral neck. And the pelvis is where the acetabulum sits, where it kind of joins the spine down to the hip joint. The knee, on the other hand, is a little bit more complicated of a joint. It's more of a hinge joint, has motion in one direction. There's a little bit of sliding and rotation in it, but essentially it functions more as a hinge. There's a lot more anatomy in a knee joint, and people talk about different kinds of injuries. We're going to focus more on the hip and knee replacement side of things. So we're not going to talk about, ACL injuries or meniscus tears grossly. But, a lot of people have questions about what the meniscus is, what it does. And the meniscus is a disc of cartilage that functions to transition the round femur to the flatter tibia, and it increases the surface area of the force transmission from the hip or from the femur to the tibia, or from the thigh to the shin. And as that degrades with time, you have progression of arthritis and more arthritic symptoms. Arthritis as a whole is broken down into kind of two different varieties. Osteoarthritis is the wear and tear, the degradation of cartilage over time from aging. On the other hand, rheumatoid arthritis is a chronic inflammatory autoimmune disease characterized by inflammation. And this can be managed with autoimmune medications, but it also tends to present earlier in life and with more significant symptoms. Both osteoarthritis and rheumatoid arthritis could be unilateral, bilateral, or throughout your whole body. Typically, patients with rheumatoid arthritis are tested for this if they present with symptoms early in life, and are managed a little bit different medically, because the medications for rheumatoid arthritis will not necessarily be useful for osteoarthritis. If you look at progression of arthritis in this cartoon, if you look at the image on the left, it's a relatively normal knee with a nice kind of uniform looking articular cartilage, nice uniform joint spaces, and normal menisci. The image on the right, on the other hand, what we see when we're in the operating room, or if you have arthroscopic images, arthritis, when it advances, leads to cartilage loss, and that presents with decreasing joint space, wear spots in the cartilage, and development of bone spurs. And one of the most common questions we get asked in the office is, can't you just take off the bone spurs? Won't that solve the problem? But unfortunately, your body is trying to build more bone to decrease where the force is applied, but removing the bone spurs doesn't really do that much. So really, when you start to get advanced arthritis with bone spurs, the real long-term treatment for the hip and the knee is going to be joint replacement. We look at kind of a normal x-ray, kind of a moderate to severe x-ray, and then a severe x-ray on the right. You can see kind of what we're looking at. The left image has the femur on the top, the tibia on the bottom, the fibula is the little bone, and then there's an asterisk where you can kind of see the patella is superimposed there. But in a normal joint, you've got this nice, healthy looking joint space from left to right that's relatively uniform. If you look at the middle image, the joint space is significantly decreased where you've got some bone on bone contact and a little bit of asymmetry from the medial side of the joint on the left to the lateral side on the right. If you look at the far right image, you'll see what's really a severely arthritic knee where you've got just abnormalities of the joint space. You've lost the nice round contours. You've got bone spurs on both edges of the joint, medially and laterally. Kind of not a healthy looking knee. And both the images on the right would both qualify for joint replacement, certainly more severe on the right than the middle, but depending on your symptoms, both would be candidates for interventions. We look at x-rays of the hip. It's a little bit more complicated because there's a little bit more anatomy. The hip joint's a little harder to see. So we've kind of outlined the socket of the acetabulum on the left side there with that yellow line. The pelvis is the big pretzel-shaped bone in the background. And then you've got the femoral head and the femur, sorry, it's double labeled for the images. Advanced arthritis, the hip, if you look at kind of the left images shows a normal hip, an early arthritic hip, and then the far right image is an advanced end-stage arthritic hip. Again, on the left side, you've got a nice uniform joint space, nice uniform cartilage lines, where kind of you've got this symmetric curve around the hip. The left side, you start to see a little bit more sclerosis or whitening around the hip, small bone spurs at the corner of the outside of the socket. And then if you go to the far right side, you see just obliteration of the joint space where you're getting some subchondral cysts, both on the acetabular side and on the femoral head. There's no real joint space, and the hip's really going out of round there. And so again, both of those hips on the right would qualify for some kind of intervention. Certainly on the right, the only long-standing one would be hip replacement. When we look at the interventions that are recommended for hip and knee replacement, there's kind of a ton of information on this slide. But what I generally tell my patients is there's really 4 things that we do for hip and knee arthritis. And the recommendations from the Orthopedic Society are pretty clear on all these things of what's recommended and what's not recommended. There's only really 3 things that are strongly recommended for arthritic treatment. Activity modification, educating the patient, changes to activity, anti-inflammatories, and weight loss. On the other hand, there's a handful of things that don't work. Acupuncture, glucosamine chondroitin is one of the quote joint juice supplements that's been shown not to be beneficial in the long run. In fact, in some standardized trials, it's actually been shown to increase joint pain. The one thing that's on there that's a little bit surprising is gel shots. We still do them at SOS. I still do them in my practice. I just don't really push them or recommend them for everyone. Gel shots have been shown not to be superior to cortisone injections, which at the bottom are listed as inconclusive. If you look at large series of patients, there's no significant difference between the outcomes of a steroid injection or a gel shot. And that is definitely different for individual patients, and I see it in my own practice. But from a standpoint of large research studies, gel shots are not superior to steroid, and that's led to the recommendation against them, mainly because the cost is significantly different. The average gel shot tends to run about $1,000 to $1,500 as a retail cost, and insurance may pick some of that up. On the other hand, arthroscopic surgery or arthritic cleanouts or having your knee scoped to have the arthritis clean out is another thing that's not recommended, neither are shoe wedges. Things that are inconclusive, steroid injections, and those are relatively frequently used. Biologic agents, narcotics are recommended against, Tylenol is recommended kind of softly for, and then bracing is one of the other common questions that comes up, and I apologize because this slide's a little busy. But bracing has not been shown to offer a significant benefit for knee arthritis specifically. The intention of a brace, particularly hinge knee braces, is to provide mechanical stability to the knee. And if there's no left, right, front, back instability of the knee from a mechanical standpoint, from your medial collateral or lateral collateral ligament, there's not a huge benefit to a brace. Now, there are certainly patients who find comfort in a brace and it's reassuring. And for the average patient, I recommend just trying a knee sleeve before going to a more rigid hinge knee brace because the compliance with them is relatively poor. But bracing has not been shown to offer significant long-term benefits in some big studies. So as we go through our recommended treatment options, there's a position from the Hip and Knee Society, and there's a couple of these throughout the talk. The position of the Hip and Knee Society, and this is a reputable source. Most all of our joint surgeons are members of the American Association of Hip and Knee Surgeons. The position is essentially that we do not use narcotics to treat arthritic pain. And if you're to the point at which you need narcotics for hip or knee pain, you should probably be evaluated for a surgical consultation. There are certainly some special circumstances, but the average patient should not be on narcotics for pain control. The biggest thing that's been shown that we try to do a better job about now is educating our patients to what non-surgical treatment is, what works and what doesn't work, and why we're doing what we're doing. And so if we talk to patients about the effects of hip and knee arthritis, about the treatments that we're trying to offer, and what we're trying to work with and why we're trying to do it, it does offer some long-term benefits to the patient because they have a better understanding of the disease. Physical therapy and rehabilitation has been shown to improve patients' pain control, increasing their functional status. And generally what I tell my patients in the office is that arthritis really is a use it or lose it situation. It's better to be mobile and painful than painless and stiff. When we do joint replacements, we only replace the end caps of the bone, and there'll be some pictures that show this later, but I don't replace muscles, tendons, or ligaments. And so if you stop moving from arthritis to control your pain, your muscles, tendons, and ligaments get stiff, and that doesn't get better after knee or hip replacement. Weight loss has a huge benefit on particularly the knee. The studies are a little bit harder to measure in the hip, but every pound of weight loss can take 4 to 5 pounds of force off the knee. So if you multiply that out, a 10-pound weight loss, 4 to 5 pounds per pound, or 4 to 5 pounds of force per pound of weight loss times 10,000 steps a day, you can get to 500,000 pounds of force off the knee every day just from a 10-pound weight loss, assuming 10,000 steps. Then one of the other things we try to recommend is if you're really symptomatic from arthritis, either a cane or a walker, and typically you want to have that on the opposite side of the hip or the knee, so it's on the ground the same time the affected hip or knee is on the ground. Physical therapy, whether it's land-based or aquatic therapy, is a good option. The YMCA in town, both in Fayetteville and in Liverpool, have great aquatic therapy programs. They have aquatic arthritic classes. That's a great option for patients who are really struggling with traditional land-based therapy, which is what I think we try to get all patients to start with. The big question that we get asked in the office kind of routinely as well is heat or ice, and I hope some people recognize the image on the right because I said it in the office a couple of times and people didn't really understand. But basically, there's no right answer. It's whatever works for you. Typically, the therapist will kind of heat you to loosen you up before therapy and ice you down at the end. As far as medications, kind of the mainstay of treatment for patients who are able to take an anti-inflammatory, have the tolerance with their blood pressure, stomach, and their kidneys is anti-inflammatories like Advil, Aleve, or aspirin. The most common ones we prescribe are generally going to be Mobic or diclofenac, with Celebrex as a second-line drug. They have huge benefits as anti-inflammatories, not just for the hip or the knee, but for the rest of the body. And for the patients who can't tolerate that, we kind of go to topical medications or Tylenol as an alternative. And Voltaren, which is a diclofenac gel, is now available over the counter and has some generic options. This was a prescription until last year. There are other topical options, and I don't recommend for or against them. I think anybody can try anything that works, but there certainly is a medical benefit to an anti-inflammatory cream versus just an anxiolytic, or sorry, not an anxiolytic, an analgesic like Lidoderm patches. Capsaicin or pepper creams have shown some significant benefits as well, and they're gaining a significant amount of traction in the literature, as is just regular Aspercreme, or Arnica is one of the herbal remedies. The big thing with Arnica or those herbal medications is knowing the strength, because the formulations are generally not regulated. When we get to injections, there's kind of two schools of thought on that, and that is the cortisone or the gels, and we generally start with cortisone for most patients. Gels are an option for patients, and that's something I encourage you to talk to your doctor about. Nobody needs to have cortisone or a gel to have a hip or a knee replacement. The gels are not approved for the hip. And in general, I tell patients, If you really want to try everything, it's okay to try a gel, but it's not going to be better to cortisone, definitely. There's certainly some patients that see the benefit. We do them not infrequently in the office, but there used to be a theory about 20 years ago that they were better than cortisone. And the studies just don't support that. And about 1 in 3 patients in my office tends to say they're great. And, half the patients kind of say they're okay. And a third of the patients don't really want to do them again. They do have a different side effect profile. So for diabetics, there's kind of a reason to try the gels because they won't affect your blood sugar. There is a whole new school of technology that's coming out recently called regenerative medicine. And we'll talk about what each of those are. The most common ones that are done nowadays are called platelet-rich plasma or stem cell. And then there's a surgical procedure called autologous cartilage implantation that's used more for younger patients. Platelet-rich plasma is something that we do offer in our office. We spin down peripheral blood, and then the top coat, what's labeled A in that image, is the platelets, and they tend to have high concentrations of growth factors that promote cartilage or muscle or tendon healing, and that can be injected anywhere for theoretical repair. Now, there are a long list of uses of PRP, and the bottom line is all of these things are considered experimental. They're not covered by insurance, and I would encourage anyone who's looking into these as a treatment option to really talk to their provider about the risks and benefits of treatment. I certainly have a couple of patients a year who choose to do it, but it's not inexpensive, and it's really something you need to discuss with the provider. Stem cell, on the other hand, again, this has been kind of blown up in the last few years. The theory is that you harvest peripheral or of stem cells and inject them into areas of treatment. Stem cells can be harvested from individuals from the umbilical cord, from bone marrow, from adipose tissue. It can be concentrated and injected into sites for repair. And if you look at one of the companies that kind of is a stem cell company selling their product, it really can allegedly be used for everything. The third option is autologous cartilage implant. This has got a little bit more science behind it. It's not necessarily targeted at osteoarthritis. It's more targeted at the young athletic population. It does involve 2 surgeries. So the first is a surgical cartilage harvest. Then the cartilage is sent to a lab where it's attempted to be grown. And then the second surgery is a reimplantation of a cartilage sheet that's supposed to heal and replace the cartilage that was lost or injured. And again, this is not a treatment for osteoarthritis. It's more a treatment for young athletes, and it's really for isolated defects. It's again considered experimental and usually not covered by insurance. The cost of this is again very dependent on where you're trying to do it, and it's not insignificant. It's also a 2 surgery procedure. Now, kind of, if you can't really tell my position, it's kind of clearer here. Both the Hip and Knee Society and the FDA have some positions on biologic agents. And I think the one from the Hip and Knee Society is pretty clear. For advanced hip or knee arthritis, biologic therapies are not recommended for treatment. There is no technology that is known in 2020, 2021, or really in the near future that I see to regrow completely worn cartilage. There may be technology for isolated defects, but I think you need to really look at what the technology is doing, who's regulating it, and what the risks versus benefits are. We have seen complications of stem cell therapy, of PRP in the area. We've treated joints that have gotten infected, patients that couldn't get hip or knee replacement in the future because of complications from the therapy. And in general, no stem cell treatment in the FDA is really regulated for orthopedic use. So I think it's very important to know that you're getting reliable treatments. And one of the things that people ask me about hip and knee replacement all the time is, am I getting the newest product? Am I getting the newest implant? Am I getting the sports model? But at the end of the day, the most reliable treatments are not necessarily the newest. If you kind of go back and think about what, I'm sure everybody's heard commercials for like metal and metal hip replacement, and the lawyers that are kind of drum up the patients. Well, 15 years ago, metal and metal hip replacement was a great idea. And it was the newest, latest, greatest thing in hip replacement. And we realized it didn't work. So the newest and latest and greatest is not always the right for everybody. And I think it's really important to talk to your physicians about the treatments that are being offered to you. So if all of those things don't work, when do you really start thinking about hip and knee replacement? Well, the real reason and time to think about it is when the pain interferes with your quality of daily living and the other treatments aren't working anymore. Generally, I tell my patients, you'll know when it's right. I don't really try to push anybody into the presentation, into surgery. And I want patients to tell me after surgery they wish they did it sooner and not that they wish that they waited. The biggest thing I'd really recommend if you're looking at a joint replacement, and I think SOS has done a great job in building a huge joint replacement program, but you want a very experienced surgeon at a very experienced surgical site. There are huge benefits to high volume surgeons and high volume centers. There are lower complications, better outcomes. And there's a slide at the end of the talk that kind of talks about the SOS outcomes. But essentially, the more surgeries that a surgeon does, the lower the complications are. The longer the surgery takes, the higher the infection rate. And so you really want to find a surgeon who does a lot of surgeries and does them well. And that data is becoming more and more public available. Some of it's available through Medicare. Some of it we publish ourselves because we have a joint registry that's got, I think, almost 10,000 data points in it now from patients. And some of it's got up to a 10-year track record now of implant surgeons and techniques. As of 2014, there were about 700,000 knee replacements done a year, 400,000 hip replacements. And that number is projected to potentially double over the next 10 years. It's certainly going to grow. The biggest benefits are increase in patient satisfaction, improved quality of life, and mobility. And the other thing that's kind of not underscored, and I tell this to my elderly patients frequently, 2 years after joint replacement, your life expectancy goes up. Patients who are older are not necessarily contraindicated from surgery if they have a longer life expectancy. I've done hip and knee replacements on patients in their 90s if they're healthy and eligible, because they really are affected on a daily basis and they have some significant benefit from it. The technology is also a lot better than it used to be. The materials that are used for hip and knee replacement tend to be super alloys. The metals are usually cobalt or chrome, which is usually for knee replacement. Hip replacements tend to be made out of titanium. There tends to be a plastic or high molecular weight polyethylene liner, and that's used both for hip and knee replacement as well as the backside of kneecaps. Ceramic femoral heads or metal femoral heads are used, and there's often combinations of all three implants. In general, the bearing surfaces for most surgeries done today tend to be metal or ceramic on plastic, which is the polyethylene. One of the newer technologies that's come out recently is robotic surgery or navigated surgery. We've had docs in the practice who've been doing computer-assisted navigation for the better part of 20 or 30 years. Robotic assisted navigation is kind of newer. I'm one of the docs in the practice who does a fair amount of Mako surgery or robotic assisted surgery, which is done at a community general hospital. Navio is the updated version of Corey, which is another robot that's used for knee replacement at both St. Joseph's and our surgical center. There are significant benefits to computer navigation for specific patients. In general, however, compared to general robotic surgery and general surgery, robotic orthopedic surgery tends to be slightly more invasive. The incisions need to be longer. There are pins that need to be placed into the bone. For hip replacement, there are 3 pins that are put into the pelvis. For knee replacement, there's 2 pins that are put into the tibia, 2 pins that are put into the femur. And our surgical incisions need to be a little bit larger to use those. It doesn't mean that it's right or wrong to use it. And there are certainly patients that I indicate for robotic surgery, particularly if they have abnormal anatomy, patients with really big deformities, prior surgery with hardware, fractures, genetic abnormalities, or just big defects that are going to make them a complicated surgery. Patients with routine anatomy, meaning normal hip and knee arthritis, garden variety alignment, don't necessarily have a huge benefit to robotic surgery, at least not today. There certainly may be data on that in the future. Robotic surgery tends to take longer, which may lead to an increased risk of infection. And so this is an option we do in our practice, and it is available, but it's not necessarily right for everybody. And I think that's the big thing. I think people think the robot's doing the surgery or just making everything perfect, and it really doesn't. It's really a secondary confirmation of what we're trying to do in the operating room. There are other ways around that. Computer-assisted navigation is one. Patients that are having anterior hip or anterior hip replacement in particular, we tend to use X-ray during the surgery, which helps confirm component alignment. And then the other technology that's used a little less frequently is patient-specific navigation or patient-specific instrumentation, which are custom implants that are 3D printed or guides that are 3D printed for patients to make their cuts. And again, in high volume centers, that tends to be a little less beneficial. For low volume surgeons or centers, it is kind of helpful to make sure things are done correctly. But I think at SOS, we do almost 4,000 joint replacements a year. We don't use a lot of patient specific instrumentation. It does come into play for patients with deformities, however. So what are we looking at for knee replacement? Partial knee replacements, you can see kind of the two that are on the right compared to a total knee replacement. On the far right is a medial unicompartmental knee replacement. On the middle is what's called a patellofemoral replacement. Those are for patients with isolated defects or issues where the rest of the knee is healthy. There is significantly shorter rehab. There's less pain, but the indications are a little bit limited. Most people do wear out the medial side of their hip or the medial side of their knee first. However, it isn't necessarily the right surgery for everyone. It is something you can talk to your surgeon about. Our partial knee replacement volume is about 5% of our total knee replacements at SOS. On the other hand, total knee replacement is more common. We replace, basically, if you look at kind of the bottom left image there, the medial part of the joint is on the right, the lateral part's on the left, and then the patellofemoral compartment is the third part of the joint. And so a total knee replacement replaces all three of those. A total knee replacement is a very good surgery for the average patient. For the right patient, a partial may be a little bit better, but you really have to be very careful and tighten your indications. And what you'll see at the bottom of this bottom images on the right is a cemented knee replacement. On the top is a cementless knee replacement. There's no significant difference in long-term outcomes of the fixation type. It's really kind of surgeon specific. Hip replacement on the other side of the coin is a little bit different. There's going to be four components. There's an acetabular shell, a plastic liner, which is the typical bearing, a femoral head, which is usually modular, and a femoral stem. And so that does typically tend to offer a very good replacement of the joint. And I think the next slide is a picture of a hip replacement. And then, the purpose of both hip and knee replacement is to reduce joint pain, improve mobility. With hip replacement, we have the ability to affect leg length a little bit. And if patients have congenital deformities, we can change their leg length a little bit intentionally to restore leg length if it was lost early in life due to deformation or hip dysplasia. And both hip and knee replacement tend to increase life expectancy. And I think now that Dr. Greenky has joined us, I'm going to try to turn the talk over to him. And Max, you want me to run the slides, or do you want to load the presentation from here?
You can definitely just run the slides.
Okay.
Yeah, absolutely. Keep it simple. Hey, everybody. Sorry I'm so late. Okay, so picking up sort of where Kevin left off. So where we do hip and knee replacements now is really different than it was 10 years ago and even 5 years ago. And COVID has sort of pushed total joint replacement in a direction that it was already going. So depending on each specific patient, how healthy you are, what your risk factors are, it can either be done as an outpatient at a surgery center, in the hospital requiring a night or two stay, or done in the hospital and going home the same day or the next day. And so what we found after looking over this is that we found that not only do patients do just as well as an outpatient, but in a lot of ways, they do better. So we're really fortunate. We have a great facility. We've been on the forefront of this and been out ahead of it. And we have our one-day surgery center out in North Syracuse near the airport. And we have capabilities there to do joint replacements, and people actually can stay there one night if they need it. So you have the surgery the same day or that day. You get up with physical therapy that same day, and depending on how you do determines whether you spend the night or not. And so I sort of touched on this before, is that, COVID pushed joint replacement surgery in a lot of directions that we were going already in terms of outpatient surgery, but we just did it, went there a lot faster. So we are trying to do anybody who is safe to go home the same day, the next day, that way. The couple things that we were dealing with are just availability in the hospitals, and then the availability to go to a rehab facility following the operation. And then, of course, we have safety protocols in place to make sure that, you don't get COVID when you get your joint replacement. You're not spreading it to anybody else. So what to expect after a joint replacement? And so this really, differs depending on a hip and knee. And then I would say it's a bell curve in the sense that it differs a lot between patients. And so I would, not compare yourself to your spouse or to your siblings or to your neighbor. The way that we do things here, we've got a protocol for everything. So preoperatively, we try to get you as optimized as possible. So meaning that that you will do as well as possible with the surgery and do it as safely as possible. When we're talking about pain control after the operation, we try to hit it from a bunch of different directions, and this has changed a lot too. So generally, we're giving you standing Tylenol, anti-inflammatories if that's something that's compatible with your medical history, narcotics if you need it, and we've that's changed a lot recently. Icing is okay, and actually, it's sort of like when you wake up in the morning, you're stiff, and you don't want to get out of bed, but then you move around and you feel better. That's how we attack joint replacements and therapy too. So we want you up and moving afterwards. Next slide. So the surgery is not without risk, and certainly if you do enough of them, then complications happen. And so they're unique to patients, but I guess the message that I would give everybody about this is if they happen, you want to choose somebody who's going to acknowledge the complications and take care of them when they do occur. The overall complication rate for us, though, hovers around 1 to 2%. Okay. So the goals of physical therapy and what to do afterwards is to regain, basically your function. And so the recovery period, like I said, this is different for hips and knees, but essentially we want you up and moving that day. And we sort of say about 6 weeks, you're 60% of the way there. But you will continue to have, recovery over, a longer period of time.
Sorry, it keeps jumping on me. It's a little.
Oh, that's okay. That's okay. That's what the faces are at. And so these are great questions that people have a lot of times after surgery. When can you return to work? When you can start driving? When can you travel? And all those things. So, and this varies a ton between patients, and also depends on which leg you have. So, work depends. But if you're a desk work, you're probably not going to feel well enough for a couple of weeks. But if you're an independent business owner and it's not manual labor and you want to get back to it, that's okay. For laborers, it's going to be longer. So driving, there's no test that we can give to say you can or can't drive. But basically what I would say is you have to be off narcotic pain medication, and you'd have to feel safe driving with a loved one in the car, whether they're with you or whether they're not. And obviously the left side, because you don't have to brake or put the accelerator on, surgery recovers faster than right side for driving. And so the whole point of doing a joint replacement for a lot of people is to get back to being active, doing the things they love doing. And, generally we tell people no contact sports, high impact activities are not great for the longevity of your joint, but we want you to golf. We want you to be able to hike and to ski and do the things that you love. The summary of this slide is what I would tell you is that this is a big problem. A lot of people are getting joint replacements, and a lot of people are really happy that they did.
So this is a slide that you guys are going to get sent to you. I think as we kind of talked about earlier in the talk, one of the most important things is to have a reliable source of information. And this is a summary of a bunch of really good reputable sources. AAOS is the American Academy of Orthopedic Surgeons. It's got reliable information through a website called OrthoInfo. So whether you're looking for hip or knee replacement information or information about other orthopedic conditions, everything that's on this website is affiliated with and licensed by the American Academy of Orthopedic Surgeons. It's kind of vetted and a good source. The website on the right, ACUS, is the Hip and Knee Association, more specific to joint replacement, a little bit of a slant towards sports as well. And there's a couple of videos, which I do encourage people to watch the Play-Doh hip and knee replacement videos. They're really cute. They're not gory. My kids have seen it a couple times. It just shows you what we do during the surgery. There's a couple of videos of a tour of our surgery center and a video of one of our patient stories, and then our joint replacement videos on the right. Our joint replacement website's on the right. So I think at this point, the moderators were going to get us to some questions, and I apologize because I didn't have Max's wife's number to get pictures of his kids. Here is our most recent edition, but I think, are there any questions?
Thank you both so much. There have been, and those kids are adorable. There have been a number of questions coming in and still more coming through. So we're going to do our best to get those all over to you. And I will say for any of those folks that have sent in some very specific questions about themselves, we do encourage you to reach out to your physician to speak very specifically about that. We're here answering more general kinds of questions tonight. So we'll start off with a question that came through. Can you have both knee replacements done at once?
So I can start off with this one. So we used to do this a lot, and all of the research shows us that it's probably not the best idea. The reason for that is you need a good leg to recover on. There's always some extenuating circumstances, based on person's functioning level and how healthy they are. But we know that the overall outcomes, the incidence of complications, are worse if you do them both at the same time.
And I would just echo what Max said. There are specific reasons, and kind of for me, it's either a significant impairment after surgery on one side or a deformity so big in the knee in particular that they can't stand. If your knee's at a 45-degree angle before surgery, left to right, and we straighten it out, you're not going to be able to stand. The other thing I kind of tell patients is the risk of dying after a hip or knee replacement is less than 1 in 10,000. The risk of dying after bilateral knee replacements is 1 in a couple hundred. So there's a significant change in the risk profile there, and that's one of the biggest reasons why we stopped doing bilateral surgery frequently.
Okay, thank you. We've had a few folks message in about hip resurfacing and the Birmingham hip method, if that's being done, if there's anything that you would want to share about that.
So, so the Birmingham hip replacement or resurfacing is a metal cap for the femur with a metal socket. So the bearing surface is metal on metal. And I kind of made a little bit of a joke earlier in the talk that, there are very specific indications for Birmingham. We've got a couple of partners that are very high volume surgeons for it. I don't think that Dr. Oreo, Dr. Greenky, or I do any resurfacings. And the reason for that is the metal on metal bearing generally does not last a patient's lifetime. The metal on metal bearing creates metal toxicity. And so that leads to degradation of the muscles, and it'll need to be revised later. The theory was that it would lead patients to be more active and have a lower dislocation risk. But in general, they have a higher revision risk than a traditional implant. And so my position, and I literally talked to Max about this last night, so I know his position as well. The most reliable replacement of the hip is a traditional ceramic on poly replacement with your implant of choice, because it has the lowest revision risk. And so neither of us do those. They are done frequently, or not infrequently, I would say. But you really need to make sure it's the right surgery for you, because there's a good chance it will not last your lifetime.
We've had a number of folks write in about some specific risks and wanting to know more the frequency of things like blood clots, hip bursitis, and hip displacement after replacement. Is that something that one of you could touch on?
Yeah. So I guess so a lot of that depends, right? So our historical data on things like blood clots, that actually came from a very different time when getting a hip replacement or a knee replacement meant you were in the hospital for a week to 2 weeks. You were lying in bed for almost a week. Now it's how we handle that is completely different. We want you up and moving, so that the incidence of blood clot is much lower than traditionally that it used to be. I don't know if I know a percentage off the top of my head, but around 1 or 2%, I think, and maybe even south of that. What were the other questions, Nicole?
They were frequency of hip bursitis and also hip displacement.
Yeah, so I think maybe displacement dislocation or instability of the prosthesis and hip replacement. So that incidence depends largely on the person, and then a little bit on the approach that we use for the replacement. So I don't know if Kevin touched on this at all, but there's different ways that you can do a hip replacement, and each one has their pros and cons. And I think Kevin, Anthony, and I all do the same two approaches. We do a posterior approach or an anterior approach, and that is solely based on each patient and what we feel comfortable is the best for that patient. So when you go in from the back, the risk of dislocation is a little bit higher, but there's some other advantages to it. But the rate is still very low, around 2 or 3%, I believe.
I would even say it's probably a little lower than that. I think the literature that I generally tell patients, it's about 1.5% in the literature right now. And if you're looking at fellowship trained joint replacement surgeons, high volume docs. And I think that, Max's comments were all completely accurate. I think blood clots are a little bit of an overblown risk in general. Generally, if a patient asks me about blood clots, when we're treating blood clots or preventing them, we're also increasing the risk of infection. You're either going to bleed or you're going to clot. And if you bleed, you're going to be higher risk of infection. So in the early 2000s, Lovenox or injections for heparin came out that were very commonly used for blood clot prevention. And there was a huge spike in joint replacement infections because patients were bleeding into their wound. And so most patients would rather have a blood clot we can treat than an infection that requires surgery. And most patients right now for blood clot prevention, probably about 90% of the practice are considered low risk and just get aspirin daily. Nothing we can give for a blood clot prevention will decrease the risk of you dying of a blood clot. So it doesn't matter whether I put you on aspirin or Lovenox or Coumadin or one of the new drugs. I can't prevent you dying from a blood clot no matter what I give you after surgery. So we're trying to manage the risk of a blood clot versus the risk of an infection. And just like Max said, when you choose your approach, everything we do, we're weighing a pro and a con, with pros and cons, whether going in from the front or the back. There's actually another approach that we don't do nearly as commonly called a lateral approach, which has actually the lowest dislocation risk, but you also limp the worst when you have that approach. So there are risks and benefits to everything. And so each question really has a follow-up when you ask it correctly, or when it's being discussed thoroughly to figure out what's the side effect of making that choice as well.
Great. We had one specific question about one of the treatments, more alternative treatments. Can you take a leave-in Voltaren at the same time? Or is that a topical?
Yep, Voltaren. Yeah. So I let my patients do oral anti-inflammatories and topical Voltaren as well. I think the risk of having an issue is relatively low. The side effects are the same. You should not be on 2 anti-inflammatory pills, but you basically should be monitoring your blood pressure and kidney function if you're on an anti-inflammatory for long term.
Yep. Agreed.
We have a question. How frequently can you have a hip or knee injection?
So that varies amongst providers depending on what their comfort level is. So what I would say is about injections, I think what you're referring to is the steroid injections. And so they're sort of unpredictable in how they work. They generally work for some period of time, but we don't know as doctors whether it's going to be a couple days, a couple weeks, or 5 or 6 months. What we do know is that generally as you get them more often, they will work for a shorter duration of time and less effectively. But to answer that specific question, for me, I wouldn't do it more often than every 3 months. And I would just expect that as you get more and more, they may not work as well.
Agree.
We've had a few folks write in about physical therapy. The first question is, can physical therapy help to put off joint replacement?
Yeah, so I think that, the long-term benefit of physical therapy is learning the exercises to do. And can it delay joint replacement? Probably a little bit. Will it prevent it? Probably not. you're trying to make yourself stronger, particularly with the knee, reduce micro instability. And it generally will, if patients are compliant, will help with pain control and delay the surgery. And the exercises that you should do are generally things I'd have you discuss with a therapist. I send a lot of patients just to 2 or 3 visits to therapy to learn what they should be doing, and get a tailored program to them. It's not something you necessarily need to be in therapy, for 6 weeks for. The one time I do send patients to long-term therapy is for trochanteric bursitis, which is a non-hip surgical issue, usually before surgery, or elderly patients who have falls and fractures. I kind of tell my patients, if I meet you through the ER as a hip fracture and I see you back a year or 2 later and you have another fall, I'm going to tell you to do therapy a month a year to work on your gait and your balance to make sure you're maintaining your activity level.
And along with that question about physical therapy, how important is going to physical therapy before your joint replacement?
I think it's pretty important not to go many times, but I think it's helpful for a couple things. One, it just teaches you what to expect afterwards. I think the more you know, the easier recovery is going to be. And 2, it teaches you how to be safe after the operation, because you're going to work with physical therapy the day of your surgery, but it's really hard to retain a lot of information when so much is being thrown at you the first day. So I think, really the value in it is learning what to expect and how to be safe afterwards.
Yeah, I agree with Max. And I mean, I'll put a plug in here for our own therapy group, because we just went through a talk a week or 2 ago about the outcomes of SOS therapy. And, with our joint registry, we've collected a ton of data. I generally send patients to pre-op physical therapy when I indicate them for surgery. And as Max said, I generally tell people to go when I indicate them for surgery, a month or so later, and maybe a week before surgery, because generally surgeries take about 2 to 3 months to get conveniently scheduled. But if you go to SOS therapy for a joint replacement, we've got a huge amount of data that shows you'll have a lower complication rate. You'll have less therapy time, less therapy visits, which translates to cost savings for you. The biggest benefit of our therapist for the docs in the practice is our therapists communicate with us on a daily basis. We've got offices that are next to our therapy frequently. And, one of the offices that both Max and Dr. Oreo and I share, and I apologize because Dr. Oreo is apparently still stuck in the operating room with some emergencies tonight. But the therapists come over every Tuesday when we're on lunch, and they go through the patients that are in therapy, the patients that are doing well, the patients they have concerns about. And we also get, messages from the therapists that aren't in the same office that kind of communicate with us. So from a pre-surgical standpoint, the benefit of going before is education, planning, and knowing what you're getting into. It's also a second set of eyes to ask questions to things that may have come up when you were in the office but didn't think to ask.
Thank you. Can you tell us the youngest patient, or who are the youngest patients that you've done hip replacements on as far as age?
The youngest I've done in Syracuse was 26. When I was a resident, we did some on patients with rheumatoid arthritis in their teens. It's very patient specific, certainly much higher risks than younger patients. The oldest patient I've done a joint replacement on, I've done 100-year-olds for fractures. I've done elective 96-year-olds, patients who are really healthy, that really have a longer life expectancy. They really do have a benefit. So, I mean, I have patients tell me all the time, I'm 85, I'm 86, I'm too old for it. But really, I've unfortunately met some of those patients back through the ER because they fell because of their knee and broke their hip, or vice versa. And so you're never too young or too old. Your risk profile is different.
Yeah, I think that's really well stated. Each patient is the same, and medicine is always an analysis of risks and benefits and pros and cons, and so you just have to weigh those and make a decision. So age, certainly, similar to Kevin in the range.
Thank you. We did have a question about can hip replacement cause one of your legs to be shorter than the other?
So it's a great question. It's one of the most common complaints after joint replacement. So often when we replace somebody's joint, it will change the length of your leg. But if you can imagine, when you have a diseased hip, oftentimes your leg is shorter or longer than the other one because of the disease in the hip. And so when we do it during the operation, we do our best to get it absolutely perfect to the other one. But it will feel different to you because you've been living with a shortened limb for such a long time. And so that feeling will generally go away within 6 months to a year. But just knowing that ahead of time can be really helpful. And I don't know about Kevin, most of the time we have tools in the operating room that allow us to get that nearly perfect.
Yeah, I think that's where we talked about both robotic surgery and using X-ray during surgery to kind of take measurements. But at the end of the day, the biggest reason why people have changed their leg length is because there are 12 sizes of implants and 12 6 to 10 sizes of femoral heads. But it's kind of like trying to buy shoes. Sometimes it's a little too tight, sometimes it's a little too loose, and we're modulating risk again. We may intentionally lengthen you a little bit to reduce the risk of having a dislocation. We may intentionally shorten you a little bit to avoid the risk of having a nerve injury. It's all playing risks at the end of the day. And that's a very, thing that I talk to patients about, day to day. Specifically, patients I think are going to have changes when we plan the surgery. We actually, plan the size of implant you're going to have before surgery. And there's some skill and estimation there because it's depending on the scale of the X-ray. But it also gives us a secondary confirmation of, yeah, we're doing the right thing. I'm within a size of where I thought I was going to be. My leg length feels right. The tension feels right. The hip is stable. So it can change your limb length, but realize we're usually making conscious decisions why we're doing what we're doing. It's just you need to ask if you have an issue, asking again the follow-up question to why it ended up that way is really important.
Thank you. We did have a question come in about what is hip revision surgery? Is that something somebody wants to talk about?
So hip or knee revision is redoing a hip or a knee replacement, and it's something that is unfortunately not frequent or not infrequent for us as well. So as patients have joint replacements at younger ages, as the technology has advanced, particularly the newer plastics that came out in the early 2000s, the revision risk has gone down significantly. But a revision arthroplasty is redoing a hip or knee replacement. It requires a higher level of skill. It's technically more demanding. It's significantly more risky, but it can usually lead to a good outcome if it's done for the right reason. But you are starting out behind the 8 ball because you're needing a second surgery. So generally, I tell my patients that have revisions, my goal is not to make you like a patient who's having a primary knee replacement, it's to make you better than you were. The reasons for revision, the most common one is infection. The second most common is loosening of the implants, which is usually related to either wear, size, or progressive breakdown of the bone implant interface.
Thank you. We've had a few questions in regard to patients' weight and hip and knee replacement, and one just came in asking if there are any new developments that will make knee replacements safer for patients who aren't able to get their BMI into an acceptable range for surgery.
Yeah. So Kevin could probably add to this too, but the main issue with BMI is actually not really wearing out the prosthesis. Certainly that can play in, but the reason that we have limits on BMI for joint replacement surgeons is because we know that after a certain level, your risk of complication goes up into a range that most of us find unacceptable. And it's just because we want to help people. And, like I said, if you're past a certain level, the risk of all of those complications that we talked about goes up, and it goes up significantly so.
Okay. Thank you. What are the chances of being allergic to the metal in a joint replacement?
Very low. So, basically there are patients who have metal allergies, and it's not an infrequent question. The patients who truly have metal allergies generally are patients who cannot wear any metal, meaning they paint their zippers and buttons with clear nail polish. They can't wear any jewelry. The metals that are commonly used have very low incidence of nickel, which is the most common allergy that we see. Titanium is generally very bio-friendly, but there are people who are intolerant to metals, and that happens. It's kind of a chicken or egg argument. Are patients allergic to the implants, or are patients with poorly functioning joint replacements more likely to be metal sensitive? And so for hip replacement, it's really a relatively low risk, because there are, generally titanium is very, very bio-friendly. And so you can get around the nickel by using a titanium socket, a titanium stem, and a ceramic head. For knee replacements, a little bit more complicated. There is a vendor that we commonly use that has a ceramic coated femur, which gets rid of the nickel. But in general, I tell my patients the implant's part of the issue, but so is the surgical procedure. The saw blades that we use to cut the bone are generally have nickel in them, and they may leave more debris in the knee or the hip from cutting the bone than the implant will over the course of its life expectancy. So it's not something that we don't see, but it's something that generally patients who have significant metal allergies know before surgery. If you don't really have issues with metal, if you can wear zippers or buttons or jewelry, it's usually not a concern.
Great. I think we're gonna have our last question here as we get very close to 6 o'clock. It was actually sent in just a little bit before the presentation. Someone that had a hip replacement 6 years ago, and they actually stayed in the hospital for 3 days during that time, and know that many of their friends did as well during that time. They understand that people are now even going home the same day, which certainly you talked about in the presentation. What has changed to or improved to allow this is what's our last question.
Yeah. So I don't think there's not one thing that's changed. It's a bunch of things that have collectively made a difference, I would say. One is expectations. Two is how the anesthesia is done. It's done in a way that you bounce back much faster. It's our management of your pain afterwards. Like I said, we've also figured out that, we basically want you to be with us in the facility or a hospital until it's safe for you to go home, and not before and not after. And what we found that is, if you're uncomfortable, you'll be happier if you're uncomfortable at home versus uncomfortable in the hospital where somebody's waking you up every couple hours and it's not your own bed and it's not your own food.
Yeah, I mean, I don't think it's a huge change in our protocols. What we found is basically getting patients moving sooner leads to better outcomes. Yeah. And so, once patients started moving faster, then it kind of was like, why are they in the hospital? And that's the same reason why inpatient rehab has gone down. If you can walk 50 or 100 feet, you probably don't need to be in inpatient rehab. And so I think that, when I got to Syracuse was 2017, and the average length of stay at that time was that kind of 3-day range. But, I usually joke that when I give these talks and that question gets asked, I usually say, well, when I was in high school, people spent a week in the hospital. When I was in college, they spent 4 days. And when I was in med school, they spent 3. And when I was a resident, they spent 2. And I was a fellow, it was 1 night. Now they go home the same day. And I think the biggest thing we found is the more people move, the better they do. And that's the whole point of a joint replacement. The sooner we can get you up and moving, the better you feel. And so there are reasons why people spend 3 days in the hospital. But the average patient that's having surgery in Syracuse right now, particularly with SOS, is probably going home the same day. Now, COVID's throwing a wrench in that because we're not doing as many inpatient surgeries. But, we're doing up to, I think we did 150 or 180 outpatient joint replacements at our surgery center last month. We're finding the patients that are able to go home the same day, that are going to do a rapid recovery, they're going to lead to good outcomes. And, you may be eligible for that, you may not, but that's a conversation to have with your surgeon about what your expectation should be from a joint replacement, what your expected recovery will be. And is it different than, my neighbor or my friend or someone else? Because there are certainly patients that I can pick in my office that are going to go home the same day. And there are certainly patients who are going to need, 2 nights in the hospital. It's not this, it's the same surgery, but everybody's got different risks.
Absolutely. Thank you. Is there anything else, doctors, you'd like to add at all before we close?
No, I just want to thank everybody for tuning in and giving us your time and your attention.
Yes. Thank you all attendees for joining us this evening. Thank you, Dr. Kopko and Dr. Greenky. And we hope you all have a great evening.
Thank you. Have a good
Bye
night.
for now.